Hello everyone, I'm Ron Waxman. We are at TCT 2010 in Washington, D.C. This is Cardiotube, and I have with me Dr. Christian Ham from Germany. Welcome.
Hello Ron, pleasure to be here.
Christian, you have been really a leader in the whole strategies of anticoagulation and acute coronary syndrome management. Let's focus today on the antithrombin inhibitors because I can see that there are some differences. Here in the US, we're using 70% bivalirudin. In Europe, it's maybe less than 7%. Mm-hmm. And you have recently discussed the issue of unfractionated heparin in the ICER-REACT-3. Give us a little bit of your view. What is the difference between Europe and the US? The patients are the same.
The patients are the same and the study results are the same, and there's no question that the study results for the acute coronary syndrome with bivalirudin, be it non-ST elevation acute coronary syndrome, in particular also the ST elevation myocardial infarction, are very convincing and very and also has a strong recommendation in the new European guidelines to give these compounds. It's indeed true that the rate of usage is rather low in Europe, and probably one reason is the price. Although GP2B3A is also not a cheap drug, but particularly ReoPro is an expensive drug, of course, but it's a price issue, and also and on the other hand, maybe many operators think that they treat their patients a little bit differently than it has been done in the studies. Like there's a lot of radial approach which avoids bleeding and things like this. But I think that's not a good argument from my point of view, because the results, particularly in Horizons, are so convincing with the reduction of mortality. You cannot get around it. It should definitely be more. There's no question.
For acute MI.
Yes, for acute MI. There should be definitely, the rate should be higher. So
unfractionated heparin is still used heavily in Europe. Is that true for general patients acute coronary syndrome during PCI?
Yeah, and then of course that's routine standard, and in most centers, and then most centers then add GP2B3A if it's a more complicated case.
And you were advocated for a long time about the 2B3A, even prior to hospitalization, and there are also not expensive agents like thyrofibrine, right? But in the US, actually, we have started to decline the use. It's probably less than 5% right now overall 2B3A, and with the other antiplatelet that we have, we didn't find that it's really adding a lot of value. But do you think that this combination of unfractured heparin and 2B3A is still holding up against the new regimens, including the fact that we do have new antiplatelet therapy?
No, I think I'm personally convinced that the bivalirudin is a better choice, but many are used over many years using unfractionated heparin and GP2B3A, and GP2B3A are not very expensive, and they do use it selectively. But I have to disagree with my colleagues in Europe. I think it's a better approach to use bivalirudin.
Yeah. And what about fondaparinux? I mean, we had two strong studies, the OASIS studies, and yet again, we don't have it approved for ACS indication in the US.
Yeah, that's the other way around. I mean,
and it seems to be actual reduction in bleeding complications, even in mortality, right?
Yeah, it was the same. It's the same in a more conservative treated patient population. I mean, fondaparinux is not a compound you use in the frame of PCI.
Correct.
And if the patient goes on for PCI, you have to add unfractionated heparin, because otherwise you increase the risk of thrombus formation in the catheter. But otherwise, it's in many places, like my place, we use fondaparinux with great success, and there was very convincing results from ACES-5 that you reduce mortality by reducing bleeding complications, similar as bivalirudin in Horizon.
Almost like equivalence, but not to the PCI. So what happens, at least in the US, we actually, as soon as the patient has, he thinks that he has a chest pain, he's already on the cath lab. So there is not much time to lead for pre-treatment with the thrombin inhibitor. Yeah. So we actually view that more as a patient on the table rather as a patient waiting to get to the table. And maybe that's the difference why in our case we don't see much. And especially when you think about fonda, you still have to, we're currently doing a study which is called SWITCH. Switch 3 is switching from fonda to bivalirudin versus heparin. just to see how safe it is to give to those patients bivalirudin. But most of our patients don't wait much time, so even on this study, the time that they're getting the fonda is a relatively short time because they get to the lab very quickly.
Sure.
Is in Europe it takes what, like 24 hours to get the patient?
That is very different from country to country. Germany, I think, has in relation more cath labs than the US probably. So here, patients are shipped very early to the cath lab. But in other countries, of course, I mean, if you go to Sweden or it's far away to the North Pole, of course, it takes some time. And of course other countries like Greece, so they don't, and the Eastern countries, they don't have that many cath labs, and so that takes longer time, of course.
So I'd like to pick up your remarks on two studies actually. One is the OASIS 8, I think the OASIS 8, the one that was actually looking on fondaparinux and using different doses of heparin in the cath lab.
Yeah.
And there was like the high dose and the low dose. Is any recommendation or take-home message that you take from this one?
Well, the take-home message is that you need to add unfractionated heparin in a lower dose, and that's safe enough for the patient.
And the ISO-REACT 3?
The ISO-REACT 3 was a study done in patients with stable angina undergoing elective PCI, and they actually tested a rather high dose of unfractionated heparin, 140 units per kilogram, against what I would consider still a high standard dose, which is 100 units per kilogram in patients. I myself use for more than 10 years around 5,000 units standard for all patients.
Regardless of their weight?
Yeah, if they are really heavily overweight, I increase to 7,500, but otherwise I see no problems. And because I think today with the background therapy of our antiplatelet drugs, clopidogrel, even maybe prasugrel in the future, ticagrelor, we probably can lower our anticoagulation during our elective procedures.
So for stable patients who come for an elective PCI, there are some people that argue that you can actually do the study with no heparin at all. But that's maybe extreme.
If you're quick enough, I believe you can do it.
Yeah, but you would advocate that the lower probably is the better, right?
But you avoid bleeding complications, and usually that is no issue. That's totally different in acute coronary syndrome, where platelets are activated, where thrombus formation really is an issue. But in stable
But if
angina,
you have an ACS, you would agree that probably bivalirudin.
Absolutely, I think that's definitely the best choice based on the studies that have been performed here.
The last question is on antiplatelet therapy. You'll have the three choices. We also going to have them at some point, hopefully. I mean, right now you have two choices, prasugrel, clopidogrel.
Yep.
You can also double the dose if you take the OASIS 7, even though there is some question about this, maybe for PCI, but and then we have ticagrelor. So how would you make the decision? Which one would you use for patients that are coming for PCI? And this is for ACS, obviously. For
ACS, then I think if you exclude the high-risk bleeding patients, that the elderly patients, the underweight patients, and patients that had a prior stroke, so then prasugrel is the best choice. I think that's very clear, and that's how we use it. But I think early next year in Europe, we expect that ticagrelor will be on the market. And the data of Plato are just convincing. If you can reduce mortality over clopidogrel, I think there's a very hard argument to switch to ticagrelor, and I'm expecting that this will really take place in Europe.
And then do you take anything from this meta-analysis that we're trying to compare the prasugrel to ticagrelor that was recently published, showing that there is some...
There's not much difference. Yeah, but of course this is from subgroups derived from
Plato. They're basically the major trials.
Yeah, but Triton and Plato are two completely different trials. Triton included only patients that really were scheduled for PCI, whereas Plato, had patients with acute coronary syndromes that were treated conservatively and that were also treated aggressively by cabbage and so on. So I think it's really a problem to compare these two trials head to head.
Great. So we did a rendezvous. We went all the way from thrombin inhibitors to antiplatelet, Europe versus the US. Thank you, Christian, for coming.
My pleasure, Ron.